So I am a doctor of pharmacy, and my official title is Pharmacotherapy Specialist in Abdominal Transplantation. And I've been doing that here at Tampa General for 20 years, but I've been involved in transplant for over 30. So I think the first and most important thing a patient should ask their pain doctor is, are you board certified in pain management? There are a lot of physicians out there that are managing pain that aren't certified to do it. And I think it's important to have somebody who is certified by a board, medical board that actually shows that they have certain level of qualifications to manage pain. So in terms of pain medication specifically related to opiates, the concerns first and foremost with long-term use is that people develop tolerance and require higher and higher doses. And so they don't get the pain relief that they need. Each time they get the dose increase, they may get some of the side effects that people like about the meds, which is the euphoria and things like that, but the actual pain control is very difficult. Also, constipation is a very big problem with chronic opiate use, and especially in patients who have abdominal pain issues. When you get constipated and distended, you get into this little kind of catch-22 of you pain, you take the pain medicine, it makes you more distended, you get more pain. So this is something we always counsel our patients who have abdominal pain. You have to be careful about how you use the opiates to control that. Also, everybody worries the big one is respiratory depression, or people will stop breathing. For the majority of patients who are on pain medications and take them the way they're prescribed, even as the doses are titrated, normally don't have problems by themselves, but when they start introducing other medications like benzodiazepines for anxiety or other things that can add to the patient's risk to stop breathing, that's when they can get into real trouble. A big one, obviously, especially in the early start and every time the doses are increased, is the sedation and inability to react. So obviously the favorite warning that pharmacists put on those medicines is do not operate heavy machinery or drive while on these medications. It can slow your reaction time significantly, and that can make for dangerous situations, and even things like walking around the house. If you're a little sedated and you're going up and down stairs, there's increased risk for falls. The elderly have significant increased risk for falls when they're on opiates. And then another big one is psychosis. So a lot of the opiate pain medications can cause hallucinations and strange thought behaviors and confusion, especially in, again, the elderly, but even in patients who are younger who are on very high doses. So in general, especially for acute pain, which is basically short-term, you're not likely to become addicted to pain medicines. I have a lot of patients who don't want to take their pain medicine when they really need to because they're concerned about that. Most people become addicted either because they're using pain medicines where they really don't need them, or because they're getting titrated to such high doses that they become addicted to not being able to reduce the doses or stop taking the medications, and so they get side effects, which are including things like fear that if they stop taking the medications, their pain will get out of control. Part of the problem is that the increase in prescribing is why the country is now recognizing this. Unfortunately, it's not that simple. The opiate crisis has many phases. It has to do with people who abuse them intentionally, doctors who prescribe them inappropriately, and also to do with people who are going doctor shopping, and they'll get a prescription from this doctor and another one from that doctor and another one from this doctor, and they get them filled at different pharmacies, so they're not easily tracked. So that's part of the problem. But the other thing is the FDA, or the DEA rather, and the states are starting to crack down and limit how much a pharmacy can dispense each month, how much a certain physician can prescribe each month. And I think that's dangerous because, for instance, surgeons who create pain on a daily basis are going to need to prescribe opiates for a lot of their patients for acute pain. Pharmacies, for instance, our outpatient pharmacy here gets limited each month on how much they can dispense. So sometimes at the end of the month, we're struggling to find ways to get pain medicines to our patients who really need them. But I think the biggest issue is not the opiates themselves, where it's related to actually controlling pain. I think one of the problems is we don't use enough multimodal approaches. So for instance, in addition to opiates, there are drugs like gabapentin, right, which is Neurontin, or Lyrica, or there are drugs like, you can use lidocaine patches, you can use capsaicin cream, you can use magnesium sometimes, and using different approaches. You can use antidepressants in the tricyclic class like amitriptyline and nortriptyline, which have excellent evidence in terms of neuropathic pain, whether it be from back issues, from diabetic neuropathy, things like that. So I think not enough physicians use multimodal approaches, and they just keep pushing the doses of opiates. And even anxiety can increase your risk for pain. So in patients who have an anxiety component to their pain, a little bit of an anti-anxiety medicine like Ativan or Xanax might actually help decrease the amount of opiates that they need to use. So I think that's one of the major issues, is the people who are out there managing pain, I don't think enough of them are qualified to do it. And the people I see come in with chronic pain for my patients, that I have to manage them acutely after their transplant and after major surgery, are not on the multimodal, and a lot of times I'll put them on multiple different drugs to minimize their opiate use, and that works a lot of the time, not all the time. It depends on the type of pain. So, for instance, with cancer pain, right, the non-steroidals are excellent for bone pain. So a lot of cancers involve bone pain and even broken bones. So rather than rushing to use opiates all the time, you might be able to reduce the amount of opiates used by alternating between non-steroidals and opiates. Now, having said that, non-steroidals carry their own risks, which include GI bleeding, kidney failure, and some people who may have allergic reactions to aspirin, for instance, may not be able to use other drugs like ibuprofen or any of the prescription non-steroidals. But they do a really good job at reducing the need for opiates, even in some of the immediate surgery patients who've got acute pain from surgery. If they don't have contraindications, a lot of times we'll do that. We'll use a drug called ketorolac, which is an intravenous non-steroidal, and then that helps reduce their need. And even acetaminophen can sometimes reduce the need. So for their milder pain, they may not need to take an opiate. And when they have severe pain, use the opiate for that. And then there are lots of techniques that are not implemented that are psychological to help patients not notice the pain as often. Hypnosis or even distraction, doing things. Find something you like to do and do it. And you find a lot of times when patients are involved and not just sitting there thinking about their pain, that they don't need to take pain medicine as often. Well, so obviously I think it's important that you try to use the medications the way they're prescribed, and that rather than going to increased opiates right away, that you ask your doctors, can we try other approaches in addition to the opiates, so we're not continuing to increase the doses. They need to understand the side effects. Constipation is a big one. Anybody who's on chronic pain medicine who doesn't have regular bowel movements should be on something to help with that. Normally what we do is stool softener, laxative combinations, and then sometimes you may need to go to even higher approaches, different drugs that actually antagonize the effects of the opiates in the intestines for people who are on chronic pain medicine. But also I think it's important that people with chronic pain look at physical therapy. I don't think enough people utilize physical therapy the way they should, and I think part of that is our healthcare system. And I can give you, my significant other can't get her physical therapy because it costs her $50 every time she goes. And if they want her to come 3 times a week, that's $150 a week. She doesn't have that kind of money laying around. So a lot of times we have things that are out there that patients can't utilize. And the insurance companies take some of the blame for that. And I think that when we look at how we're going to fix this opioid crisis, we need to look at all of those different things and not just restrict the prescribing of opiates.